My name is Ron Mataya. I am an associate professor of global health at Loma University in Southern California. And I currently work in Malawi, which is my home country. I come from the central region of Malawi, from a little town called Dedza, which is between Blantyre, the commercial city, and Lilongwe, the capital. My parents are since deceased, but I have a brother. I have two brothers and three sisters. I come from a family of 6. And I'm married to Jean, and we have 2 children, 2 adult children, Lulu and Andrew. I teach in the School of Medicine in the Department of Obstetrics and Gynecology because I'm a gynecologist by training. And so the College of Medicine invited me to be part of the faculty. And so I spend a lot of time in both the family planning clinics, the gyne clinics, the prenatal clinics, and the general services, and teaching students and residents in the College of Medicine. We put together what is now the Malawi Laboratory Capacity Consortium. The program is to strengthen lab capacity to deliver improved services around HIV and AIDS treatment programs in Malawi. We work with the Ministry of Health hospitals, which in Malawi deliver about 65% of healthcare services. 35% of healthcare in Malawi is provided by what is called the Christian Health Association of Malawi. So the way we put together the consortium is that Loma University, being a faith-based organization, which is associated with the Adventist hospital called Malamulo Adventist Hospital, which for a long time was the only laboratory training school in the whole country. And because of that association, Loma University works with Christian Health Association hospitals to improve the lab services. And University of North Carolina works with the Ministry of Health hospitals. The Christian Health Association hospitals are strictly speaking, the other services are supervised by the Secretariat of the Christian Health Association of Malawi, which is actually an advocacy body for government to support Christian Health Association facilities. And so the way it is in Malawi is that all national employees of the Christian Health Association of Malawi, hospitals affiliated to it, or members, are fully paid by the ministry. Their salaries are fully paid by the Ministry of Health. And so it does play an important role in making sure that those budgets are covered. So whether they are Catholic hospitals, Episcopalian, Methodist, Adventist hospitals, all the local staff are paid by the Ministry of Health. The program entails re-equipping hospitals, retraining of lab technicians, both in-service and pre-service training, as well as training the lab technicians in improving their skills in maintaining simple maintenance of equipment. And so we have really comprehensively improved the specialized tests that are done for HIV, as well as the regular tests that are needed for other services, such as simple hematology tests. The family planning clinics are interesting in the sense that you are seeing more and more Malawian families or Malawian women. It's predominantly women who come. Occasionally you'll get a couple coming, but certainly the injectables remains the most popular method, by far the most popular method, and that's followed by the combined oral contraceptives, and the implants are becoming more and more popular. and of course the condoms. I think what is also interesting is the fact that we are seeing more and more couples who are either both HIV positive or discordant couples where one is HIV positive, wanting to use some form of family planning or wanting to have children. And so that's something that we have to deal with in a very sensitive way by providing the kind of services that they require or asking for. And so we have to have people specially trained to work with couples who are HIV positive and or discordant couples. We have nurses all the time who are specially trained, and if they want to see physicians, the gynecologists or our residents are there to meet with the couples if they want to get special counseling. There is still a lot of stigma, both self-directed, directed to self by those who are HIV positive, and of course by those who are. It's less, but certainly much less than when we first started working with people living with HIV. But there is still some form of stigma by healthcare providers, by families and friends, and employers. Like I said, it's less. Yes, it is less, but it still exists. It's more now. It's more open. I mean, certainly, again, if you go back 20 years ago, it wasn't. There's been a major shift in how we talk about it in churches and communities. Those who haven't worked in developing countries have a hard time accepting that is actually the situation. When you tell them that or a woman couldn't get to the hospital because there was no ambulance, when here we're used to having a helicopter fly out and pick up a woman, or you call 911 and the ambulance is there, or the fire department is there, and they, I think people have a hard time understanding that those conditions do exist in many countries around the world. Transportation is a major issue, yes. I think for me, I've counted it a privilege to have been able to live and work in the U.S. and live and work in Malawi. I think that the fact that the CDC PEPFAR grant has allowed me to do that, to be able to spend more than 60% of my time in Malawi while I teach full-time at Loma and do research is a privilege that shows that a faith-based institution can partner with non-faith-based institutions to improve services in the private sector, which is the Christian Health Association of Malawi hospitals, as well as the government sector, and that shows that I think wisely we can wisely use state facilities, state funds to improve health around the world. And that's great.